Good evening, everyone, and welcome to the Statewide PHN Immunisation Forum. My name is Katrina Pilbeam, and I am the Manager of the Workforce Education and Capacity Building at Western Victorian Primary Health Network, and I'll be your facilitator for this evening. This forum is the opportunity for healthcare providers to hear the latest updates and insights from our guest speakers from the Victorian Department of Health and the City of Melbourne. For the second time this year, the Victorian PHNs have come together in a collective effort to deliver the statewide PHN Immunisation Forum. Covering a broad range of immunisation related topics, the statewide PHN Immunisation Forum will provide updates on the national and Victorian immunisation program and immunisation catch-up in relation to migrants new to Australia. I would like to start by acknowledging the traditional owners and custodians of the unceded lands and waterways. We recognise their diversity, resilience, and the ongoing place that First Peoples hold in our communities. We pay our respects to the elders, both past and present, and commit to working together in the spirit of mutual understanding, respect, and reconciliation. We support self-determination for First Nations peoples and their organisations. A little bit of housekeeping today. So for today's session, participants will remain on mute for the course of the webinar. Should you have any questions, please type them into the chat box. We will have a short Q&A at the end of each presentation, where we will answer as many questions as possible. Please note that the information session is being recorded and will be available for viewing for 30 days on the VicTAS PHN Alliance website, along with any resources that have been shared. The presentation slides and a link to the recording will be shared in a post-session email to all registrations shortly after the webinar. Please note that attendance and evaluation data is shared between the participating Victorian PHNs for attendance and evaluation purposes. A statement of attendance, which can be used to self-report your professional development points. We will not be applying for CPD points on your behalf. The important information for tonight's webinar is that the information shared is for information purposes only and does not take into account individual circumstances. Practitioners will need to make their own personal professional judgment on a case-by-case basis. Health Pathways, a reminder about Health Pathways. It's a free online resource with localised clinical and referral information for health practitioners, including nurses and allied health clinicians. And you can contact your local PHN for further details. We're very fortunate to have an outstanding cast of speakers for this evening's webinar. The first presentation from the department, we will hear from Catherine, Sophie, Josie, and Monique, and that will be followed by a presentation from Philippa from the City of Melbourne Council. So without further ado, we'll move on to our first presentation for this evening from the Victorian Department of Health. Thank you, Catherine.
Thanks so much. Perfect. Very quick. So just next slide, please, Monique. So before we begin, the department would also like to acknowledge the traditional owners of the country throughout Victoria and acknowledge their continuing connection to land, waters, and community. We pay our respects to the people, the cultures, and the elders past, present, who may be joining with us today. So thank you very much for everyone who is dialing in to the statewide Victorian PHN Immunisation Forum. For those who don't know me, my name is Catherine, and I head up the immunisation program at the Department of Health. Just a really quick background in relation to what it is that we do and why is there so many of us from the department on the call. So the immunisation program is responsible for overseeing all government-funded immunisation programs across Victoria. So that includes delivery of the National Immunisation Program and state-funded programs. Our unit comprises of 3 teams. So we've got a vaccine operations and systems team, which is pretty much responsible for vaccine logistics and ensuring that vaccines get to immunization providers. There's a lot of support and data that goes behind that. We also have a clinical team, which, as the name sounds, is responsible for providing clinical advice, education, and guidance to immunization providers and all the immunization programs across Victoria. And finally, we also have a projects and policy team, which is responsible for leading, developing, managing, and contributing to policy and projects in relation to vaccines and immunization, and that includes legislative and regulatory immunization work. So there's members from most of those teams that will be taking you through a variety of topics today. And just on this slide, it provides a little bit of detail of what we'll be discussing. So the NIP, maternal vaccination, state programs, including measles and Japanese encephalitis, and pneumococcal vaccination. So with that, I'll hand over to our senior epidemiologist, Sophie Wilson, to guide us through the first section. Thanks, Sophie.
Thanks, Catherine. I'm just going to run through some immunisation coverage data. So we'll start by looking at the childhood rates. So the fully immunised coverage for childhood cohorts has continued to decline, and this decline has been seen nationally since 2021. Fortunately, we have seen a bit of plateauing in the last 12 months, but the coverage does now sit below that 95% national target for all 3 age cohorts. Next slide, thanks. So at the last PHN Immunisation Forum, the department presented on vaccine uptake trends in all age groups. And tonight, I'd like to touch briefly on some trends in on-time vaccination. So this refers to vaccination within 30 days of the recommended age. So in 2024, on-time vaccination remained lower in young children than before the COVID-19 pandemic, with a continued downward trend. And in the last quarter of 2024, on-time coverage of the second dose of dTpa containing vaccine was about 6.3 percentage points lower than in the first quarter of 2020. On-time coverage of the first dose of MMR vaccine was 11.4 percentage points lower in the last quarter of 2024 than in the first quarter of 2020. So across childhood and adolescent cohorts, we're now seeing that 1 in 3 children received their first dose of MMR vaccine late in 2024, so that one's due at 12 months of age. 1 in 5 children received their second dose of dTpa containing vaccine late, so that one is due at 4 months of age. 2 in 10 adolescents had not received their HPV vaccine dose by the age of 15 years, which is provided in the school program in Year 7. And 3 in 10 adolescents had not received the meningococcal ACWY vaccine by age 17, which is also provided in the school program in Year 10. So this is a really complex picture, and I'm just going to touch briefly on the National Vaccination Insights Project, which aims to identify barriers and drivers of vaccination to inform strategies to improve vaccination uptake in different populations across Australia. So the National Vaccination Insights Project was established to provide routine evidence-based insights into vaccination barriers and drivers across Australia. This month, the project released its first comprehensive report identifying key barriers to timely childhood vaccination and outlining strategies to improve uptake. The report was published in October of this year, and it's based on a national survey of 2,000 parents and input from immunisation stakeholders. The report highlights the wide variance in barriers and enablers to vaccination, and we see differences in barriers based on geographic location, number of children, and vaccination status. The project is a collaboration between the Murdoch Children's Research Institute, NCERS, and the University of Sydney's Social and Behavioural Insights in Immunisation Research Group, and is funded by the Australian Government Department of Health and Aged Care and the NH&MRC. And it's guided by diverse stakeholder advisory group, including the Victorian Immunisation Program, NACCHO, and other key health and community organisations. It also represents evidence-based practical strategies to guide policy and program design aimed at improving vaccination access and acceptance, including enhancing provider communication training and using behavioural data to inform program design. So we'd strongly encourage you all to review the full report and summaries on the NC's website, and also to visit sky.org.au for resources to support conversations with parents and carers about vaccination. So moving on to some adolescent data. So also shown in the 2024 NC's data, the greatest decline in immunisation coverage has been in adolescents. For example, coverage of at least one dose of HPV vaccine in adolescents turning 15 years old has been decreasing at concerning rates since the COVID-19 pandemic. So the greatest declines have been between 2023 and 2024, with coverage for girls dropping to 81.1% and for boys to 77.9%. The declines for Aboriginal and Torres Strait Islander adolescents have been even greater. Coverage of at least one dose of HPV vaccine in these adolescents turning 15 years old has dropped below 80% for girls and below 70% for boys. So overall, HPV immunisation coverage is now sitting well below the target set for cervical cancer elimination in Australia by 2030. Just one slide back, yeah, that. So just highlighting another adolescent vaccine, immunisation coverage for meningococcal ACWY is sitting lower than the other adolescent vaccines. So coverage of meningococcal ACWY in adolescents turning 17 years of age dropped to 71.3% in 2024. And furthermore, coverage of meningococcal ACWY in Aboriginal and Torres Strait Islander adolescents has dropped to 61.1%. And that's quite concerning because Aboriginal and Torres Strait Islander populations are particularly vulnerable to meningococcal ACWY infections. Next slide. So most adolescent vaccinations are given in school-based programs, which are coordinated by the local councils. And the decline that we've seen in adolescent vaccination in this setting is quite complex. So as we saw earlier, 2 out of 10 adolescents had not received an HPV vaccine dose by 15 years of age, and 3 out of 10 had not received an adolescent dose of meningococcal ACWY vaccine by 17 years of age. Primary care settings with the established relationships with families are quite well placed to support on-time vaccination and catch-up. And there is an NCS webinar on the 5th of November, which aims to provide insights into some of the barriers and drivers of adolescent vaccination and strategies that can be used to support uptake. So strongly recommend that you listen in, and if you're not able to, it will be hosted afterwards on the NCS website. And so lastly, I'm just going to very quickly touch on some influenza vaccination rates. So immunisation coverage for influenza has also been declining since 2022. Coverage in 2025 is similar to last year in all cohorts, except those aged under 5 and those aged 65 years and over, where it's sitting lower than in 2024. So coverage rates have been particularly low for children 6 months to less than 5 years, which is an eligible cohort for administration of flu vaccines by GPs, hospitals, nurse practitioners, and local councils. And looking at flu administration, the vast majority of flu vaccines in Victoria in 2025 have been administered by GPs, followed by pharmacists, public hospitals, commercial providers, and local councils. So every immunisation provider can help to improve influenza vaccine uptake. And a big reminder that the biggest enabler to uptake is the recommendation from a trusted health professional, especially for children receiving their vaccines. So I'll just now pass over to Josie. That's it from me.
Thanks, Sophie, for running through all of that. I just would like to give a bit of a recap on the great progress that we had this year with the Respiratory Syncytial Virus Mother and Infant Protection Program, known as RSV MIP. So it was the first year this year in 2025. There were 2 components. So the introduction on the 3rd of February with the RSV vaccine Abrysvo for pregnant women, and it's now a year all-round program. And the second part was the RSV monoclonal antibody nirsevimab, free for eligible infants under different state and territory programs. The dates in each territory and state aligned with the RSV seasons, and there's quite a variance across Australia. And you can see, for example, in the Pilbara in WA, they will be running an all year round program. But in Victoria, our peak RSV season is typically April to September. So in 2026, Victoria will again offer an nirsevimab program fairly similar to that offered this year, and further information will be coming soon. But for now, let's have a quick look at the uptake of maternal Abrysvo vaccine in 2025 and the role of primary care in this success. Thanks. So in Victoria, this is a national snapshot. In Victoria, provider types are slightly different to the categories collected in this picture. Nevertheless, it's really important to note that over 50% of doses were administered in the GP setting, showing the roles that GPs play in shared care and in sole care of pregnant women. Over 20% of vaccines were administered in hospital settings and 15% in pharmacy, noting there are quite a few pharmacies co-located on hospital sites as well. Victoria itself is seeing an estimated uptake of almost 70% of eligible women, noting some difficulties in identifying immunisation received during pregnancy in the air. And we note that the antenatal indicator has been added to the Australian Immunisation Register this year, and that will be critical to ongoing program surveillance and evaluation. And we'll touch a little bit on that later in the presentation. So the Victorian Department of Health, in partnership with Monash University, is conducting a mixed methods evaluation of the 2025 RSV MIP. This includes a focus on the first year of our publicly funded infant RSV monoclonal antibody program. We're seeking feedback from immunisation providers to understand what worked well and identify areas for improvement. And your insights will help shape further consultation sessions and guide enhancements for next year's program. You're invited to complete a short anonymous survey and share your experience and perspectives on RSV vaccine supply, distribution and service delivery. Surveys are currently being distributed by email, but you can also access the survey through this QR code and link. If you believe that someone else in your team is better placed to respond, or you'd like to share this survey with your colleagues, please feel free. We appreciate your time and input, and the survey will close on the 21st of November. Any questions regarding the survey, feel free to contact us at immunisation@health.vic.gov.au. Next slide. Tonight we'll spend a little bit of time discussing vaccination during pregnancy. So women who are planning pregnancy, are currently pregnant or breastfeeding, should be supported and empowered to make informed decisions about vaccination. In an era of increasing global misinformation, disinformation, it's really essential women receive accurate and evidence-based information about both the benefits and potential risks of vaccination. And the conversations obviously should be always informed by current reliable advice based on expert recommendations. So as providers, we need to arm ourselves with the latest information. Women planning a pregnancy should ensure immunity to measles, mumps, rubella and chickenpox, as these infections can pose significant risk to the babe if contracted during pregnancy. And other vaccinations such as hepatitis B may be recommended depending on individual risk factors. COVID-19 vaccine should also be considered based on personal risk and the current ATAGI guidance outlined in the handbook. The Royal Australian New Zealand College of Obstetricians and Gynaecologists, RANZGOG, recommend antenatal vaccine against influenza, pertussis and RSV. These vaccines protect both the pregnant woman and infant in early life. And these maternal vaccines are funded under the National Immunisation Program, and we'll explore that in a little bit more in the coming slides. So as immunisation providers, we all play a vital role in promoting vaccination during pregnancy, and your advice and support can significantly influence a woman's decision to vaccinate. Research consistently shows a clear recommendation from a trusted healthcare professional is one of the strongest factors in a patient's decision to vaccinate. So we ask that during routine pre-vaccination screening, ask women of childbearing age about the possibility of pregnancy. This helps to avoid inadvertent administration of live vaccines when they're contraindicated. And women who receive live vaccines should be advised to avoid becoming pregnant, if possible, for at least 28 days following vaccination. We hope the summary that we provide tonight supports your practice, and always refer to the Australian Immunisation Handbook, resources on the NCS website, and resources on the Sky website. Thanks, Monique. So influenza is the most common vaccine preventable disease in Australia, and while often mild, can cause severe illness, hospitalisation or even death, even in healthy individuals. Pregnancy brings physiological changes that place additional stress on the heart, lungs and immune system, and pregnant women are more than twice as likely to experience serious complications from influenza, including hospitalisation, with the risk even higher for those with underlying medical conditions. Influenza can lead to serious health issues such as pneumonia, bronchitis, myocarditis, and lead to premature delivery. Infants that are under 6 months of age are at the highest risk of severe influenza complications, including pneumonia, bronchitis, encephalitis, myocarditis, sepsis, and even death in previously healthy babes. And as infants under 6 months are too young to be vaccinated, maternal immunisation during pregnancy is the most effective way to protect them. Vaccination is recommended during every pregnancy, can be safely administered at any stage. There's no evidence of increased risk of adverse pregnancy outcomes from influenza vaccination. It's safe for both pregnant and breastfeeding women. And the influenza vaccine can be co-administered or given at the same day as a whooping cough booster, RSV or COVID-19 vaccine if indicated. The vaccine, influenza, is funded under the National Immunisation Program. Next slide, please. We'll pop on to whooping cough. Pertussis is a highly contagious bacterial infection of the respiratory tract affecting people of all ages, but children aged 5 to 9 are the most commonly infected, and infants under 3 months of age at the highest risk of severe illness and death. The symptoms include severe coughing fits, often ending with a distinctive whoop, may cause vomiting, exhaustion, or even broken ribs in children, and recovery can take up to 3 months. Now, infants under 6 months are too young to be fully vaccinated, so they would not have finished the schedule. And without maternal vaccination, we know that pertussis can cause 1 death and over 200 hospitalisations annually in Australian infants under 6 months of age. Vaccination during pregnancy, again, is the most effective way to protect newborns, providing passive immunity via antibody transfer across the placenta. This reduces the risk of pertussis in infants aged 3 to 4 months by 90%. It's recommended for every pregnancy, including closely spaced ones, with the optimal timing between 20 and 32 weeks gestation. And the reason for that is antibodies begin transferring from 13 weeks and they peak around 30. Antibody levels peak 2 weeks post-vaccination, ensuring protection from birth. So there's a grand window in there for maximum protection. Pertussis vaccination is safe for mum and babe, so no increased risk reported in global studies, and again is free under the National Immunisation Program. A few additional notes is that women vaccinated shortly before pregnancy should be revaccinated when pregnant, ideally after 28 weeks to provide protection to the babe. If at risk of preterm birth, the recommendation is you can vaccinate as early as 20 weeks. And if inadvertently vaccinated before 20 weeks, no repeat dose is recommended, as there will be some antibody transfer. And if not vaccinated by 32 weeks, the recommendation again from ATAGI is to vaccinate as soon as possible up to delivery to protect the mum and for some antibody protection. Next slide, please. So RSV, common viral infection that affects the respiratory tract, and in Australia nearly all children will catch RSV at least once within their first 2 years of life. And while RSV can occur year-round, peak transmission in Victoria occurs during autumn to winter, so April to September. It can be very severe. Infants under 3 months of age in their first season have the greatest risk of severe disease compared to children in all other categories, including some risk factors, medical risk factors, and are more likely to end up in hospital for treatment. Those serious complications include pneumonia and bronchiolitis. Again, vaccination during pregnancy is the most effective strategy to protect newborns from RSV in their first 6 months of life. The maternal vaccine Abrysvo is recommended from 28 weeks, ideally 28 to 36 weeks gestation, when transplantal antibody transfer is the most efficient. And clinical studies have shown that maternal vaccination reduces the risk of severe RSV illness in infants by approximately 70% and hospitalisation by 60% in their first 6 months. The RSV vaccine is well tolerated, with adverse events comparable to other maternal vaccines such as pertussis and influenza. Common side effects include local injection site reactions, fatigue and headache, and serious adverse events are rare. Abrysvo, if needed, can be safely administered alongside on the same day as other recommended vaccines in pregnancy, including influenza and whooping cough and COVID if indicated. But a big reminder that there are no RSV vaccines currently licensed for use in Australia to be used for infants and children. So this vaccine's on the National Immunisation Program for pregnant women only. Next slide, please. There's a myriad of resources to support vaccination in pregnancy from the Commonwealth and at a state level. The Sky website provides evidence-based information and resources to support conversations with consumers who have questions about vaccinations. There's quite a number of questions and Q&As for both health professionals and consumers on that website. Additional materials include fact sheets and tailored resources for discussion with pregnant women and Aboriginal and Torres Strait Islander families. The Australian Government website contains a number of consumer brochures available for digital download and can also be ordered in hard copy. And Victorian Government RSV immunisation web pages, but the DH web page and Better Health channel. There are webinars from the RSV MIPS season launch, one in December 2024 and January 2025, including presentations by Professors Michelle Giles and Nigel Crawford regarding RSV disease, efficacy of maternal RSV vaccination, and information regarding nirsevimab and its impact. And the web pages also include a range of downloadable resources and posters, including decision aids to support practice. The page will be refreshed again for the 2026 season, along with the seasonal influenza web page. And we strongly encourage you to explore and share these resources to support informed vaccination conversations. Next slide, please. Very quickly. Earlier this year, a new antenatal indicator was added to the Australian Immunisation Register, allowing providers to report if a person's pregnant at the time of vaccination. Reporting this information is now mandatory for all immunisation providers, and there's some detailed guidance on the NCA's website, NCA's AirTip, February 2025. Accurate antenatal data helps ensure that AIR contains a complete and reliable data set, and we use that for monitoring coverage and evaluating vaccine safety and effectiveness, and this supports maternal vaccination programs. So there's an important deadline here. Software providers must update their systems by the end of this month to include the antenatal indicator and remove the antenatal option from the vaccine type field. If this hasn't been done yet, for any software-related questions, you need to contact your software provider promptly. Thanks. Next slide, please. I'm going to hop back into measles, which I know we have presented a few times recently, but we're going to touch on it again. It's highly infectious acute viral illness with an incubation period of 10 to 14 days before the start of symptoms, spread by contact with infected nasal or throat secretions from coughing or sneezing, or via infected aerosol particles, and the virus remains active and contagious in the air or on infected surfaces for up to 2 hours. And by golly, the airport and planes are just ripe for infection. Measles usually starts with a fever and severe tiredness, followed by cough, runny nose, and conjunctivitis. And in children, that just seems like a normal viral illness, doesn't it? But it's followed by a red maculopapular rash that looks like lace, usually starts on the face or neck and then spreads downward to the whole body. The serious complications can include blindness, encephalitis, and pneumonia. And anyone who presents with signs and symptoms compatible with measles should be tested, isolated, and notified to the local public health unit immediately. Certainly anybody who has been travelling or visited exposure sites with this clinically compatible illness should be reported immediately, should be isolated and reported immediately. So we know global case numbers of measles are rising across multiple regions, including Asia, Europe, North America, Africa, and the Middle East. And we've seen over the past 12 months growing outbreaks reported in multiple neighbouring countries, which Australians frequently travel to, including Indonesia, Vietnam, Thailand, Cambodia, and the Philippines, Malaysia, Pakistan, and India. In fact, any overseas travel at the moment could lead to measles exposure. Now, we know measles vaccine coverage rates in Australia are below 95% national target, and the most recent measles cases in Victoria have occurred in people who have not had 2 documented doses of MMR or measles-containing vaccine. So who's at risk, really? Anybody born during or since 1966 without documented evidence of 2 valid doses of measles-containing vaccine or documented evidence of immunity. Victorians born between 1966 and 1992 may not have received 2 doses of the vaccine due to schedule changes. Young infants, pregnant women, and people with a weakened immune system are at increased risk of complications, and new migrants and refugees who have not been able to complete vaccination schedules for various reasons are certainly at risk. 2 doses of measles-containing vaccines are required for optimal immunity, and in most people that provides 99% protection. Let's now have a look at vaccine access to the funded vaccine. So there are a number of programs that are currently available to provide free vaccine. So under the National Immunisation Program, the 2 schedule points are 12 months and 18 months. So MMR being provided at 12 months and an MMRV at 18. Catch-up is funded for people up to and including 19 years of age, and refugees and humanitarian entrants of any age. As you're increasingly aware, the National Immunisation Program, access to free vaccine, is linked to eligibility for Medicare benefits. The Victorian Government has run a funded program from 2018 to provide free measles vaccine. It's been available for all people born during or after 1966 without evidence of 2 valid doses of MMR containing vaccine or serological evidence to immunity. For infants aged from 6 months to before 11 months of age prior to overseas travel, and this dose is in addition to the scheduled MMR vaccines recommended at 12 months and 18 months under the NIP. The Victorian Government program includes people who are not eligible for Medicare. So as immunisation providers, we ask you to talk to your patients to raise awareness of measles and the importance of immunisation, encourage on-time vaccination, offer catch-up vaccination for children and adults of any age, and remind overseas travellers to check their vaccine status prior to travel. Next slide, please. So as previously noted, the coverage for completion of dose 2 of MMR schedule by 24 months continues to decline, along with rates of on-time vaccinations. And these figures remain below the 95% threshold required to interrupt measles transmission and achieve herd immunity. Assessing adult immunisation status is really challenging due to historical changes in the Australian Immunisation Register, which means that not all vaccination encounters for older people have been recorded. Many adults born before the introduction of the 2-dose schedule have still not received the 2 doses of measles-containing vaccine. So to address this, the department's providing grant funding to local public health units to develop locally tailored initiatives at raising awareness of measles vaccination, increasing vaccine coverage to reduce the risk of local transmission. Victorian local public health units work in partnership with the Department of Health to promote health and wellbeing in their local communities. Leveraging local knowledge, community relationships and direct engagements, local public health units are well positioned to deliver targeted public health responses and initiatives. Now, each Victorian local public health unit will design its own approach based on its own local needs and will soon begin engaging with local primary health networks and primary care providers to support these strategies. We expect some communications to start to be distributed from next week. Thank you very much for listening to me for an awful long time, and now I'll pass on to Monique.
Thank you, Josie. I'm just going to touch on Japanese encephalitis and your role in prevention. So mosquito bite prevention still remains the most effective protection against Japanese encephalitis and other mosquito-borne diseases, but vaccination is a highly effective additional strategy to reduce the risk of infection. So the Victorian Japanese encephalitis vaccination program commenced in March 2022 following the first human case detection in Victoria. And it continues even through the upcoming mosquito season, which will start in November of this year. To be eligible, free vaccine is available for priority groups, including those not eligible for Medicare. So please visit the Department of Health Japanese encephalitis webpage for more details. There's 2 vaccines offered. Imajev is the preferred vaccine for most eligible individuals. It's a single-dose live attenuated vaccine. There's also JSpect, which is available for pregnant or immunocompromised individuals. Booster doses recommendations have been updated. So they're recommended 1 to 2 years after the primary course for individuals who have received Imajev and were under 18 years of age at the time of their primary dose or received JSpect as their primary dose. So please refer to the Australian Immunisation Handbook for booster recommendations, precautions and contraindications. ATAGI advises that as both vaccines use the same virus strain, a booster with either vaccine is expected to provide a satisfactory immune response if a person is eligible for that vaccine. So please review updated eligibility and booster criteria via the Department of Health JE webpage. Please promote and offer JE vaccine to eligible individuals. Recall patients due for booster doses. And regarding ordering, please continue to order the vaccine via the routine fortnightly process, but limits do apply. So if you do require additional stock, please contact the immunisation program before submitting your order. And you can refer to the 1-week vaccine ordering template for instructions. And also report all Japanese encephalitis vaccinations to the Australian Immunisation Register. During the last mosquito season, GPs were the primary contributors to the JE vaccine delivery across Australia. But again, it's important, and say this again for repetition, it is important to encourage people to continue protecting themselves from mosquito-borne diseases even after vaccination, as mosquito bite prevention is still the most effective measure against any mosquito-borne disease, including JE. The department has created some enhancements to the department's JE webpage guidance, including a number of case studies to support immunisation providers, determine eligibility for primary schedule and booster doses of JE vaccine. So check that out as well. Moving on to pneumococcal. So from September 1, 2025, Prevnar 20 replaces Prevnar 13 and Pneumovax 23 on the National Immunisation Program childhood schedule. This change streamlines the schedule and increases protection as Prevnar 20 covers 7 additional pneumococcal strains compared to Prevnar 13. So another one of the changes is that all Aboriginal and Torres Strait Islander children in Victoria born after the 1st of March 2025 now receive 4 doses, 2 months, 4 months, 6 months and 12 months, aligning Victoria with other states and territories for national consistency. And Prevnar 20 will also replace Prevnar 13 and Pneumovax 23 for children with specified medical risk conditions, with dosing tailored by age and diagnosis. So please refer to the Australian Immunisation Handbook for more details. But importantly, children who have started their schedule with Prevnar 13 should complete it with Prevnar 20 for all subsequent doses. There is no current change to the adult pneumococcal immunisation schedule under the National Immunisation Program. So for all of you wondering what do we do with our excess stock of Prevnar 13 and Pneumovax 23, there are no current changes to the adult immunisation, adult pneumococcal immunisation schedule so far. Our program area receives quite a few email queries about recommendations for medical risk conditions and which conditions are funded under the National Immunisation Program. So I'm not going to talk through this slide, but I've popped it up here just to remind health professionals that there is a table in the pneumococcal chapter of the Australian Immunisation Handbook that lists the medical risk conditions and lists the conditions which are funded under the National Immunisation Program. So it's important then to consider the age in which the medical risk is diagnosed and apply the recommended schedule for pneumococcal vaccine as advised in the handbook. So just as an exercise, we thought we would do some case studies. So this first scenario is a 6-month-old infant who has received Prevnar 13 at 2 months of age and 4 months of age. So they require Prevnar 20 at 12 months of age. And the rationale is that children who start their schedule with Prevnar 13 or a 15-valent PCV should complete it with 20-valent PCV or Prevnar 20 for all subsequent doses. So this ensures the broader protection against additional pneumococcal strains and aligns it with the updated National Immunisation Program. The next case study is a 9-month-old infant newly diagnosed with a medical at-risk condition. They're 9 months of age, so they've already received Prevnar 13 at 2 and 4 months of age. They require Prevnar 20 at the time of diagnosis. In this case, it will be at 9 months of age. For follow-up, this child will still require Prevnar 20 at 12 months of age, or 2 months after the last dose, whichever is later. In this case, it'll be at 12 months of age. And the rationale for this is that children aged 6 to 11 months with a newly identified risk condition who have not received an additional dose of Prevnar 20 at 6 months should receive this dose at diagnosis. Our next case study is again a 9-month-old, but they're an Aboriginal and Torres Strait Islander. They're born on the 15th of February 2025. They live in Victoria and they have no medical risk conditions. They've received Prevnar 13 at 2 and 4 months of age. What do they require? They require their Prevnar 20 at 12 months of age. And the rationale for this is that these changes affect Victorian Aboriginal and Torres Strait Islander infants that are born after March 2025. Our final case study is a 12-year-old who's been newly diagnosed with a medical at-risk condition. They've received their routine NIP vaccines. They require a single dose of Prevnar 20 at diagnosis. And the rationale for this is that all children and adolescents aged from 12 months to 18 years of age, less than 18 years of age, with a risk condition are recommended to receive a single dose of Prevnar 20, providing enhanced protection for those at increased risk. Oops. So we would like to highlight that clinical support is available. That includes the Australian Immunisation Handbook, which is your go-to reference for all immunisation recommendations in Australia. And for the most up-to-date version, we highly recommend the online version. But there are specialist services available at the Royal Children's Hospital, at Monash Medical Centre. And if you have any general clinical queries related to vaccination to support care planning for your patients, you can contact the immunisation hotlines at the specialist immunisation services. And they're available to answer questions about immunisation across all age groups. For children, adolescents or adults with complex needs who cannot safely receive vaccines in community settings or who require specialist assessment and support, a formal consultation with these services can be arranged via GP referral. And this includes those who have experienced an adverse event following immunisations. Now let's just talk about what happens if you encounter an adverse event following immunisation or a vaccine error. Mistakes can happen. So if you do encounter an AFI or a vaccine error, SafeVic is here to support you. So in Victoria, unexpected adverse events following immunisation and vaccine errors should be reported to SafeVic, our vaccine safety service. They play a key role in keeping safe immunisation practices and public confidence in vaccines. SafeVic offers expert immunisation safety advice to both immunisation providers and to the public. They also provide support to providers in responding to adverse events following immunisation or vaccine errors, as well as assistance with clinical follow-up and education for providers and members of the public when needed. So you can report an adverse event following immunisation or a vaccine error to SafeVic via online, which is available 24/7. Or you can email requesting support, or you can call SafeVic on a Monday, Tuesday, Thursday from 10 a.m. to 2 p.m. and their details are on their website. And we strongly encourage you to utilise specialist immunisation services when needed and to report serious adverse events, vaccine errors to SafeVic promptly. This will help us improve vaccine confidence and support increased uptake in the community. I'm handing back.
Thank you so much, Catherine, Sophie, Josie and Monique. Before we move on to Philippa, we've got a number of questions in the chat, so we might just, I'll ask them, and be great if we could get some answers for our participants. So the first one is, will pharmacists be able to administer FluMist to children next year? And if so, from what age?
I can take that one on. So Victoria has not announced a state-funded FluMist program. So any FluMist that is available would be through the private market. In relation to pharmacists, we have not undergone changes to the authorizations to the current way that influenza is delivered. So at this point in time, it would not be available through pharmacies. But of course, that can change because we're continuously reviewing authorizations.
Thanks, Catherine. Is there any avenues for adults to receive the meningococcal vaccine for free?
Is this just specific to meningococcal B? I'm assuming, but it is available through the private market. But maybe I'll hand to Josie if she wants to elaborate.
Sorry, was that meningococcal in general or relating to AIDS?
It doesn't say, it just says meningococcal vaccine for free.
Yeah. Look, meningococcal vaccine is available under the NIP for people at all ages with specified medical risk conditions as identified in the Australian Immunisation Handbook, so those are the target guidance. Outside of that, both vaccines are available for private purchase.
Thanks, Josie. Is Victoria going to support all adults and children with flu vaccination?
So I can take that one on. We do have free influenza vaccine available for eligible cohorts through the National Immunisation Program. But if this is in reference to a similar program that we ran in 2022, where there was a campaign, influenza for free for all Victorians, that was a one-off campaign, and we have not repeated it since.
Thank you. Can Josie please repeat the years of birth when only one dose of MMR may have been given, please? Were the dates 1966 to 1992?
It's a little bit of a contentious range. So in 1992, the recommendation changed for a 2-dose schedule in November 1992. So the schedule was promoted through primary care, but we do note that targeted programs began to happen late 93, 94. So, you know, I think there's a little bit of leeway, and it's probably safer to say, look at your cohort born from 1996 who haven't had a 2-dose schedule. So look at your people really around the ages of 30 to 45 or 30 odd, 32 to 59 as a cohort.
Thanks, Josie. Elaine asked about sharing the software slides. So just so everyone's aware, we are sharing the recording and the slides post the webinar, so you will receive that. If someone has finished their childhood schedule and later in life diagnosed with an at-risk condition and receive Prevnar, would they then get Prevnar at 70 years as per NIP?
So again, that would be an individual risk-benefit assessment, and that would require individual medical assessment of that and recommendation.
Thanks, Josie. So that's all the questions in the chat. So now I'd like to hand over to Philippa Holland from the City of Melbourne Council to present on immunisation catch-up, challenges, tips and tricks for overseas migrants new to Australia. So thank you, Philippa.
Wonderful. Thank you so much for having me. So I'm Philippa, the coordinator of immunisation for the City of Melbourne. So thank you very much for having me. In this slide, I'm talking about lots of the challenges that we sort of have learnt on our journey through doing lots of overseas catch-ups. And then just some of the tips and tricks that hopefully we can maybe help you, or you might have also experienced yourself. So respectfully acknowledge the traditional owners of the land, so the Wurundjeri people of the Kulin Nation. And this is just an image of Wā the Crow, which is from Aboriginal Melbourne, which is a spiritual protector of the Yarra River. Okay, so I thought I'd do a little bit of a background into some of the research that we have done at the City of Melbourne. At the beginning of 2016 was the no jab, no play policies that came into place. And we suddenly saw a really increased need for catch-ups with migrants. Since 2016, we saw many complexities around the catch-ups and also a lot of lack of knowledge from all immunisation providers and also lack of knowledge and understanding from parents. So due to this, we reached out to the MCRI and we said, we've probably got like, this would be a really good project to work on. And with their help, we also sort of won a GSK immunisation grant in 2020. We then had a phase 1 to 3 project, which we then reviewed all of the data from our clients and catch-ups that we did. We did surveys of parents, and then the last phase was also interviews with providers. In our first phase, the data that we reviewed from 2016 to 2020, we reviewed 1,403 catch-up records, which showed that only 23% of all the people coming in from overseas were actually up to date with our schedule. So that was over 1,000 children that were still needing vaccines. Most of them were all under 5 years of age, so 85%. Vast majority also, yet again, did not have Medicare. They came from 49 countries. At the time, about 61% was from India, which was the largest percentage. And then it was China after that. Now, currently, it's changed a little bit. So India is probably about 30% of all the immunisation catch-ups that we see, and then closely followed by China. And then at the moment, probably Indonesia and Saudi Arabia. Most of the parents found out about our service through word of mouth. So it wasn't through sort of official channels, but more from people that they knew in Australia who'd already come in. And most of them would only need one visit to become fully immunised. Most of them would need a meningococcal vaccine, and just remembering that sort of in around 2016-17, it was still meningococcal C on the program. Almost half of them needed measles, mumps, and rubella vaccine, or a tetanus, diphtheria, and pertussis vaccine, about a third of them. And we also lost about 7% of children to follow up. In the phase 2, the online surveys, some of the things that we observed from the surveys was that 30 of them spoke English as a predominant household language. However, in saying that, most of them did have very good English speaking understanding. Very highly educated people that were coming into City of Melbourne, with 91% of them completing a tertiary or postgraduate qualifications. And they were also very highly regarded with immunisations, with most of them having absolutely no concerns with immunisation, and only one reported that they delayed vaccine. Highly motivated, and some of the reasons for the motivation was to protect their child at 61% and to do the right thing to attend kindergarten and school. And then there was obviously a lot of barriers, with 23% reporting restricted access in attending education services, with a lot of them only finding out that they needed an immunisation history statement when they were trying to apply for daycare or school. The phase 3, we interviewed councils and GPs, so 24 providers. Some of the barriers included the time taken to complete and complexities, lack of education and being self-taught, which can lead to errors, lack of systems to calculate catch-ups, issues with uploading air, lack of automated reminders and follow-up, and limited and inaccurate funding. And then some of the recommendations were migrant families are not well considered in the Australian National Immunisation Program. System improvements are required to support the service delivery to migrants. General practitioners had limited time, skills and motivation for catch-ups. Resources and training are needed to support catch-up scheduling and reporting. And funding the provider's time to calculate the schedule would overcome most limitations. Migrant records, for most of you who have probably done immunisation catch-ups, this is what some of the migrant records can look like. So I thought I would quickly put a few together. I think every week that goes on, you think that you've seen them all, and then you get another record and that you're like, okay, well, this is quite interesting. And they're almost like a little bit of a puzzle, and they can also be quite frustrating at the same time. I thought I'd give you like an example of some of the catch-ups that we do at City of Melbourne. So we do still prefer to do them manually. We find it to be the most sort of easy way to write down and kind of calculate what we know is due. We also like to make sure that we're sort of educating the parents on also vaccines that are also invalid, basically given sort of out of the recommended times. For example, like you might be able to see, but at 9 months an MMR was given. And so we've just written that invalid too early. And that is also a dose that we would not add on to the Australian Immunisation Register as an example. There's lots of tools that you can assist you. Obviously, always refer to the Australian Immunisation Handbook. It can be quite overwhelming with all the information in the Australian Immunisation Handbook, but generally under the catch-up section, you will find hopefully what you're looking for. The World Health Organization also has a great portal, which you can actually sort of look at to see what the immunisation schedule of the country is. And that example that I've got there is from India. And then there's also these great foreign language terms and tables, which will then have all the trade names of all the vaccinations in the world and the antigens for that vaccine, and also most languages with the antigens, so you can help look at those. There's obviously lots of translating and interpreting services which are free, but sometimes this can be a barrier to families who really need their immunisations up to date quickly. So sometimes just referring to their records and with their help, most of the time you can actually kind of work out what antigens are valid or not. But if you're unsure or just feel that something's incorrect, then you're absolutely have your right to actually ask for them to get officially translated. Immunisation catch-up calculator, the Australian Immunisation Handbook. So this is reasonably new. I haven't used it many times, but it's actually quite good. It's a lot better than this South Australian immunisation calculator. Some tips with this is the name of the brand sometimes don't marry up with the histories from overseas. So what you can actually do is you go to enter vaccine history, and then you can put in vaccines, and then under enter vaccine, if you scroll off the purple shade to only show Australian NIP vaccines, what that will do is help you to then show towards the bottom of the screen a lot of the antigens which are then generic. So for example, you can put in like a generic hepatitis B in instead of having to put in a brand that it might not say what the brand is, or it might be a different brand to the brands that we have in Australia. Another thing with the catch calculator is once it comes up with some recommendations, if it comes up in grey for the top picture on the 24th of January 2025, hepatitis B, there's a note there that says given under the minimal interval from previous dose. When it's in grey like this means it's under what the recommended interval would be for Australia if we were immunising from now onwards, but it was still accepted by the Australian Immunisation Register. If it's in red, for example, under the 1st of August 2025, this MMR was given under the minimum interval of 11 months and therefore would not be accepted at the Australian Immunisation Register. So if you get anything like this and then you are going to upload it to the EAR, I would, for example, add the hepatitis B in, knowing that it will be accepted, and the measles, mumps and rubella, you can add it, but it would be accepted, but they will still say that they will need another dose, if that makes sense. And now I'm going to go on to sort of antigen tips and tricks. So with hepatitis B, the Australian Immunisation Register accepts a minimum interval of 4 weeks between any hepatitis B vaccine doses. So this includes between dose 2 and 3, which ideally you would normally want 8 weeks. And it says under the catch-up section, this allows children who have been immunised using 3-dose schedules typically provided overseas to be considered as fully immunised. All infants should receive the final dose of the primary hepatitis B vaccine course at greater than 24 weeks of age. However, if overseas, if the final dose was given before 24 weeks of age, but over 16 weeks of age, the dose does not need to be repeated. So it's very common for lots of countries overseas to give their last hepatitis B dose before 24 weeks of age. Most countries now do this, even, for example, New Zealand, England, they all give their hepatitis B around 5 months of age. So if you have a child who has their last 3rd dose of hepatitis B, and as long as it's over 16 weeks of age, that dose doesn't necessarily need to be repeated. Hib tips and tricks. There's a few issues with the Australian Immunisation Register when it adding the 3rd dose of Hib from overseas. It will show up with a possible error, which is under the minimum interval 115. Although, please trust your judgment that it actually is probably over the minimum interval, and it's just an error in the system and they are aware of it, and sometimes you just might need to ring the EAR to get this fixed. However, and the top picture will sort of show an example of a vaccine given all at 6 months, but somehow the Hib will move all the way up to 18 months, which can be quite confusing. And always refer to the Hib table, catch-up table, because you just won't remember that off the top of your head, and that's one of the tables you probably always will need to refer to. MMR, many countries will give the first dose around 9 months, and some might even give it from 6 months of age. So just a reminder that 2 further doses are still needed if given prior to 11 months of age. And we only really add in the doses 11 months and over, just to make sure it aligns with our schedule. And the reason why is just so that there's no sort of issues going forward, as you just need to be mindful that if you did add a dose prior to 11 months of age, you just need to really make sure that if it's a routine 12 months, that you're adding in dose 2 instead of dose 1. Otherwise, it can sort of sit in pending, depending on the software that you work with. Some countries are still giving measles and rubella vaccines, and some with single months. It's getting a little bit less now, but you still need to be mindful that you're giving 2 doses of the 3 antigens for them to be fully immunized, and you can actually split up this and then add it in as generic measles separately, as an example. Meningococcal, it's important to know the brand of ACWY. For example, Nimenrix and Menquadfree, you only need 1 dose 12 months and over. Menveo, you still need 2 doses 12 months and over with an 8-week minimum interval. Menactra, if they're under 2 years, a second dose is still needed. However, in saying all of that, AIR will still accept any ACWY vaccine, and if you add it in generic, it will still show up as then fully immunized. It is still also common for many countries to give polysaccharide vaccines with an A or C strains only, for example, China, and you will still need to give a conjugate ACWY vaccine. In adolescents for meningococcal, the AIR statements will now show up with ACWY due once they're 16.5 years old if they have had a dose prior to 14 years of age. And they say healthy adolescents who have received an age-appropriate complete course of ACWY in the past should receive a dose of ACWY after they turn 14 years of age. Some people, if they have had a polysaccharide vaccine overseas, and these are some of the brands that you can find maybe on a catch-up, I will point out from my experience that it's now very rare that there are polysaccharide vaccines in the world. Most do use conjugate vaccines, but just to be mindful of that if they're between 14 and 19, that they probably will need a conjugate dose still, but they also need to make sure that it's 6 months after, that there's a gap of 6 months. Polio. So oral polio is interchangeable with inactive poliovirus, and all oral polio doses are considered valid. It's common for many countries to give more doses of polio than we do, including at birth, which won't be accepted. We only add in the doses that align with our schedule, and I'll go into that a little bit more in the next slide. But I just also put in this picture because now these are all the countries that the orange is countries in the last 12 months have actually had polio notifications, which is quite fascinating and scary at the same time, considering we almost eradicated it. The 4th and final dose of polio needs to be given greater than 3.5 years of age. However, AIR will not show this up on the immunisation statement if more than 3 doses have been added into AIR prior to 3.5 years of age. So it's very common that some of them will then show up at 4 years of age with just dTpa due and no polio. But if they are 4 years of age, you would still give the routine 4-year-old immunization with polio. Pneumococcal. So going on from what the department just sort of said, but if they have received any pneumococcal doses, 7-valent, 10, 13, or 15, these will all be accepted by the AIR. And it is recommended to complete the schedule with 20-valent if it is due. And if they have received all of these before, they don't need to have any dose. And then always refer to the pneumococcal catch-up schedule as well, because that will also be another table that you will always keep referring to just to make sure that you're getting it correct. Another thing to be really mindful is Penta, which is 5 antigen vaccines. So these are all different depending on what country you're from. So for example, India, there's no polio in the Penta. China doesn't have any hepatitis B in the Penta. But in Australia, Influenza Penta, although it's not on the immunisation schedule at the moment, it will come up under the AIR. And you just also need to be very mindful that Influenza Penta in Australia actually has no HIB. So when adding in some of these vaccines that aren't the same vaccines as what we have, it's really important that you add them in as sort of generic antigens. So this is what we would probably do, is add them in separately for every antigen given. Minimum age is accepted and don't need to be repeated. So at 4 weeks of age, if any of these antigens are given from 4 weeks of age, instead of 6 weeks or 2 months, they do not need to be repeated. Hepatitis B, as I mentioned before, dose 3 at 16 weeks. As long as it's been given 6 weeks and over, it doesn't need to be repeated. And then the 12 months immunizations, including MMRV, will be accepted from 11 months of age. At 16 months, the 18-month immunizations, so dTpa dose 4 and Hib dose 4 will be accepted from 16 months. And the 4-year-old immunizations, so polio dose 4, dTpa 4 or 5 will be accepted from 3.5 years of age. Immunization statements, just be really mindful when reading what's due, because and this is when you need to sort of use your clinical judgment, but they do not identify additional vaccines recommended and funded for people at-risk conditions. Immunisation providers should always determine additional vaccines recommended based on individual risk assessments. And then also would need to refer to the Victorian schedule as well to just make sure you're not missing anything. And it's, as I've mentioned before, it's very common them to not show what's due. For example, polio or pneumococcal are 2 common antigens that don't always show up correctly, although they're needed. And then how to record immunizations overseas. Obviously, you can encounter directly onto the ear. Sorry, I just skipped a slide. You can obviously still do it through your software practice, whatever you find easier, and you can still send them in. So I'll just go back. You can upload them onto the ear immunization history form, but you just need to remember that can still take up to 14 business days. And letters, health records, phone calls, or stat decks are not accepted. A little bit, how am I going for time? Not too bad. Recording encounter functions on the air site. It's really important to just try and make sure that you identify the individual and make sure that there's no profile for them so that a duplicate record is not created. If there is no match, and this is very likely if they don't have Medicare, then a message will appear for you to ask you to include extra details just to double check that you really are looking for the right person. And then you would then click record encounter. When recording on the site, every date encounter, you will need to choose the country of immunization, and you will also need every single date that you put in, you'll also need to click on the antenatal indicator. And it is really frustrating because you have to do that for every single date. Only 5 antigens per date can actually be added in. So sometimes you might actually have to do it twice if there's more than 5 antigens. The batch number isn't mandatory to add if you're adding from overseas. If there are any errors or issues with that, you can actually type in not recorded as one word, and that should override it. The route of administration is also not mandatory, and then vaccine type would be other. It's just important to note with the Australian Immunisation Register again that it's basically brand that it will sort of pull from. And this is another reason why we use generic antigens quite a lot. It means that there's less errors or partially processed. For example, another sort of thing that the air does is for Twinrix, as an example, it only actually recognizes at the moment hepatitis A. And so if you are actually giving Twinrix, some people might have found this, but you actually then need to manually add in generic hepatitis B into the system. Other sort of general tips and tricks with catch-ups. If a previous vaccination cannot be confirmed, assume that the person has not received the vaccines. They will only experience injection site reactions, increased reactions for tetanus, diphtheria, pertussis, and pneumococcal. It's very rare for other adverse events that would be associated with a repeated doses of immunizations. Previous infection is not a contraindication to vaccination. More practical to offer vaccination than laboratory testing. However, consider laboratory testing for the following antigens, so hepatitis A, B, MMR, and varicella. It's not recommended for any other antigens, and you need to just consider the time and also the stress to the child or client. Please try to give all overdue antigens in the first visit and do not defer. Inactivated vaccines can be given at any time before or after other inactivated vaccines. It's always important to give a copy of the vaccination schedule and the vaccinations given. And then also just be very cautious if the client has seen another provider, because that's sometimes where confusion can happen and sometimes errors. I just wanted to also point out a little bit about funding within council, that councils, we don't actually get funded for this. So a lot of GP practices like to refer into council services, but also just be very mindful that depending on the council, we get very limited funding. So the most that we would get for calculating a whole catch-up and actually administering immunizations, if they're under 7, would be $20. We would get absolutely no money if they're 7 years and over. And not all councils are able to offer timely catch-up service due to limited funding, and every council has a different procedure and timelines. There's lots of air resources that can help you, and there's a link that you can go to all these resources and you can print them off, and they will help guide you through step by step when adding into the air. And then just some more resources and links that can help you. A lot of them I've already mentioned. And then there's just some of the publications from the migrant program that we did, and that is me. Thank you very much.
Thank you so much, Philippa. We've just got a few questions into the chat, and we have about 5 minutes left. So I've seen more than 90% of patients in their 20s who were born in Australia and fully vaccinated with Hep B, but have no antibodies to Hep B. How effective is the Hep B vaccination program if patients don't seroconvert?
That question is well out of my scope of practice, so I can't answer that.
No problem. Can take that on notice and see if someone else can help us. Next one, just wanted to clarify with the Hep B schedule. I thought the minimum interval between doses 2 and 3 is 8 weeks.
Yes.
Has this recommended changed?
No. So absolutely. If you get, for example, a 4-month child and they might have, say, had 2 doses overseas, then you absolutely would follow that recommended interval. So absolutely, you would make sure that there's an 8-week gap, and you'd really make sure that they're over 24 weeks of age. But for purposes of catch-up for people who have already had hepatitis B from overseas, it's okay. They will accept anything 4 weeks, as long as it's a 4-week minimum interval and as long as they're over 16 weeks of age.
Thank you. I think you answered this one, but due to the inability of migrants being able to access GP appointments in regional areas, there are a lot of catch-ups coming to the council nurses. There is no funded allocated for the time required to complete assessments and communicating with families. Is there any avenue to consider funding to support catch-up work?
Yes, I think we need to, and I think this is when we need to just keep advocating for councils. And I think regionally it's really hard because, for example, you can have like a new hospital that's set up or a workplace that suddenly takes on migrant workers, and it is a real struggle. More also needs to be done and letting people know prior to actually coming into the country of what the things that they need to be caught up with. But yeah, we need absolutely the funding of what we receive is it just can't cover the service. So ratepayers will be paying for this. There is options. Some councils are starting to charge. So charge for the service as well. But unfortunately, because we don't have access to Medicare items, we can't actually, charge Medicare.
Do you think that AIR will remedy the issue with twin wrecks? I have queried this.
They definitely are aware of that issue. I think the system's great. Like, it's a great register. We're so lucky to have it in Australia. It's decades ahead of most registers in the world. However, it is quite outdated, and there is quite a lot of things that would be amazing if they could improve on. But I haven't heard that they're aware of it. I know that, but I'm not sure how long it was going to take to change.
Thank you. There was another question, but Josie has answered that one in the chat. Thank you. What's the best email to follow up with questions regarding flu miss questions? So,
I can't answer that one, sorry.
Sorry.
Yeah,
it depends on what the questions in relation to flu mist are, but you can always email immunisation@health.vic.gov.au. So that's the best contact point for the department.
Thank you. The next one Josie has answered in the chat, which is great. And we've got another one. Due to the inability of migrants. Oh, yep, that's about the regional ones. And can Monash Hospital help with catch-up vaccinations? I'm unsure about that, or if anyone on the call would know that.
I can help with that one. It's mainly Monash and Royal Children's assist with specialist immunization services. That's what they're funded for. It is really difficult in relation to catch up, and it's work that really needs to be done at a national level to get, I guess, better funding, so it's recognized how complex it is. So we very much are aware of all the hard work that councils do, and we do try to advocate, but there's more that needs to be done.
Thank you. And are vaccines funded for children without Medicare?
Depends on what the vaccine is. So under the National Immunization Program, you do need to have a Medicare card, but for state-funded vaccination programs, you do not. Again, not the best policy. So if it is tricky, if there's any particular questions, encourage you to email us at immunisation@health.vic.gov.au, and we can help work through the problem. But again, it's something that all the jurisdictions have been advocating in relation to for it to be for all people in Australia, not necessarily Medicare card holders.
Thank you. That's all the questions. So once again, I'd like to thank Catherine, Sophie, Josie, and Monique from the department, and Philippa from the City of Melbourne. We do have an evaluation for completion today, so please provide your feedback. It's really important to us that we receive your feedback to improve our presentation and hear your feedback. So thanks again, and the QR code is on the screen and the link is into the chat. So thanks everyone.